Hello, how's everyone doing? I am Dr. Jonathan Johnson with Comprehensive Wound Care Services here in the Washington, D.C. area, and happy to discuss this great clinical presentation for today. First of all, I'd like to thank everyone for attending this, which will be very brief, and we will hit some of the major concepts in looking at closing the gap on racial disparities in the diagnosis of chronic wound infections, specifically concentrating a lot of our data and our time on skin pigmentation and the role of fluorescent imaging and how we can reduce some of the healthcare disparities and increase our knowledge in taking care of patients that have various skin tones. I do have a couple colleagues that have worked very hard on this presentation. We've all worked together. They are listed here, and we are very, very thankful for their inclusion as well as all of their contributions. So, as we know, skin tone diversity is lacking in wound care. And let me preference that with it's actually lacking in medical diagnostic books and periodicals and education in general. And how many of us have actually been in our clinical studies and seen various types of skin changes and skin pigmentations as diagnostic thought processes? Not a lot. So our goal here is to look at some of those changes with bacterial load and how that relates to the increase in skin pigmentations, which is the increase of melanin in your skin. So as stated, there is a gaping lack of knowledge and evidence in how skin tone impacts pathologic manifestations in wound care. This specifically translates to poor outcomes. So what does that mean? We look at bacterial loads and we focus on how to heal the wounds by decreasing the amount of bacterial loads. But unfortunately, this type of diagnostic workup can be non-inclusive of patients that have darker skin tones. Now, what does that mean? Basically, a lot of clinicians have issues being able to diagnostically look at wounds that have high bacterial concentrations and high bacterial content in patients that have higher skin tones. And we'll discuss that as we move through a little bit more in the presentation. So diagnostic indicators such as infection and erythema presently depend on the level of pigmentation. And a lot of times when we're looking at those patients and we're looking at those wounds, our diagnostic presentation, our diagnostic workup, a lot of times focuses on skin that does not have increased melanin and does not have increased skin tones and skin pigmentation. So with that being said, and not to be laborious on the concept, we're looking at some of our objectives. So we want to determine how the reporting of clinical signs and symptoms of infection differs by skin tones with an emphasis on erythema, as well as explore the fluorescent imaging, MolecuLight, as a more equitable solution for detecting some of the pathologic wound bacteria in chronic wounds. And you can see definitely by the pictures how those skin changes and differences from a clinical standpoint can sometimes decrease our ability to see wounds having a high bacterial rate. So some of our study methods, we looked at 300 chronic wounds, and we came up with an awesome acronym, FLAG, which stands for Fluorescent Imaging and Assessment Guidance. So we looked at this clinical trial focusing on three major bullet points. One was patient skin tone. One was the clinical signs and symptoms of infection, and then wound total bacterial loads, which was diagnostically looked at with MolecuLight. Now, Fitzpatrick skin tone prototypes essentially is a diagnostic characterization where we look at the skin's effects from the sun and exposure to sunlight. So it focuses on the amount of melanin that's in the skin. And usually the Fitzpatrick scale is used by clinicians to help protect skin that is more vulnerable against that increase in sunlight. So if we look at our scale, we can see that there are 6 different types. You have your light and your light or low FP scale 1, which looks at a light, as well as the patient who tends to burn easier. You look at your Fitzpatrick number 2, beige color that usually burns, your FP3, which is more of an olive and a light brown, sometimes burns. Your Fitzpatrick 4, which is light to medium, rarely burns. Your 5, which is a darker brown, never burns. And then your FP6 or Fitzpatrick 6, typically never burns, and it's a very dark skin pigmentation. So we took in the study these 6 definitions of your FP scale and broke them down into 2 different subsets or 3 different subsets with the 2 diagnostic FP scales. So our low is going to be 1 to 2, medium is going to be 3 to 4, and our high is going to be your 5 and 6. So this is our clinical diagnostic look with the MolecuLight. Now, again, we're using the fluorescence to focus on decreasing or increasing our ability to diagnose increased bacterial load and also treat from an increased bacterial load standpoint. So the MolecuLight fluorescence imaging device and procedure helps us do that effectively. So we're looking at our standard look or our standard photograph or picture, and then our fluorescent, which we can see on the left side of the screen, moving from left to right, our low skin pigmentation. We can definitely see that there's areas of a red or pinkish hue, which shows an increase in bacterial load. And then as we move to the more whitish look, we're looking at the cyan, which is more diagnostic of Pseudomonas. But either way, we're looking at the ability to see that increased amount of bacterial load in patients that have a Fitzpatrick scale of low, which is your 1 to 2, medium, your 3 to 4, and high, which is your 5 and 6. Now, this helps us focus on which patients we need to treat proactively, whether that's debridement, whether that's topical or PO-based antibiotics, or whether that's some other adjunct form of treatment, because now we know the amount of bacterial load on the wound site. So what does all this mean, you ask? We're using erythema to detect the areas of infection, typically from a clinical standpoint. But one of our major issues based on the increase in Fitzpatrick scale in some of our patients is that erythema is detected less often in higher skin pigmented patients. So 2 great points here. Clinicians are flagged up to 5.6 times fewer wounds that do have erythema in patients with highly pigmented skin, despite equal bacterial loads. And our whole point here is that this relates to a decreased ability to treat the patient and diagnostically make sure the wound can improve. So from a MolecuLight standpoint, we're looking at diagnostically being able to detect the bacterial load on the wound, and then therapeutically being able to treat it from a standpoint of looking at the progress of the wound after debridement, looking at the progress of the wound after a cellular tissue product, etc. The key here is that darker skin tone patients typically have a less clinical sign from the provider based on the skin tone. So some of our results based on that study of the 350 or so patients, fluorescent imaging allowed clinicians to identify more at-risk clinically infected wounds. Now, this improved across all standards using the MolecuLight. So sometimes based on the patient's skin tone and their Fitzpatrick scale, specifically if it's a higher Fitzpatrick scale, you're less likely, or the provider is less likely to detect an increased risk of infection and increased bacterial load. But using the fluorescence MolecuLight, we can now see those changes as described before with the red or pink hue, which indicates bacteria, or the cyan color, which also indicates pseudomoments. So the benefit was pronounced for patients with the highest skin pigmentation, corresponding to a 12-fold increase in detection sensitivity. Basically, that means that we are focusing on treating the entire gamut of Fitzpatrick scale and being able to see where there's increased amounts of bacterial load. Now, when experts went fluorescent imaging, interpreted the results, the sensitivity increased by about 56%. So how can this help us reduce disparity and specifically help treat our patients more effectively? Number one, we're educating ourselves and our colleagues about how to accurately diagnose infection in patients that have higher skin tone. We can use this equitable and diagnostic methods, such as our fluorescence imaging, to increase our ability to treat patients that have an increased bacterial load. And it helps us exercise a higher acuity of clinical suspicion when assessing for infection and deeply increased bacterial load-based chronic wounds in some patients that we may not be able to discern from just a clinical picture. Great question. I appreciate it. So one of the major issues focusing on treating all your patients is that you have a wide gamut of patients that you tend to work with, and sometimes you're not focused on being able to tell the clinical difference of increased bacteria in patients that have darker skin tones. And for me personally, from a clinical standpoint, we work with all different types of patients. And the most important thing is to focus on treating all of them. But this also gives us a resource to focus on the fluorescence side of increased bacterial load in patients that have an FP from 3, 4, 5, and even 6. Well, some of our findings were actually pretty surprising because the fact that the majority of clinicians were unsure or underdiagnosing infection in chronic wounds because patients had a darker skin tone was very surprising. And again, this goes back to a lot of the literature that we typically see, going through our medical training, et cetera, where we don't see a wide gamut of patients of skin of color, as well as patients that are non-skin of color, and being able to diagnostically look at each one of those patients, not only from wound care, but a dermatologic standpoint, a plastic surgery, general surgery, podiatry, et cetera. And so again, the findings were based on the fact that a lot of those wounds were not clinically treated because of the discrepancy in the higher FP patients that prevented the physician or the provider from moving to those diagnostic and therapeutic treatments of the chronic wound. So what I would take away from this, and I hope all my colleagues do as well, and all of the folks that worked on this study, is that to have a higher acuity, to look at skin changes that could be indicative of infection, like erythema, et cetera, in your patients that have higher or more skin of color. Basically, your patients that have a Fitzpatrick 3, 4, 5, and 6. You want to make sure that you're evaluating their skin and their wound more proactively because of their changes or because of their skin color. It could decrease your, forward progression in taking care of the patient. So again, the takeaway, as I ramble on, the takeaway is that just have a higher acuity of suspicion in patients that typically could have chronic wound infections and increased bacterial load in patients with an FP of 3, 5, 4, and 6, or the darker skin tone. We are continuing to move forward with looking at changes in clinical indications as far as wounds are concerned in patients with skin of color. And we will continue to look at different places of service, physicians' offices, wound care centers, hospitals, because it really changes your mode of treatment and your ability as a diagnostician to see the wound, treat the wound, and make sure the wound continues to improve. So to answer your question, yes.